Right. What I thought I would do this morning is a little different from the presentations I usually do, because I usually don't talk a lot about vaccine rollout per se, but I do want to give you some background on the virus and the disease that it causes, because I think it is helpful for you to understand something about the biology in order to understand the decisions that are being made around vaccine safety and efficacy, around what do the new variants mean. What about the new vaccines that are coming up? How are we going to be able to adapt if new variants become the dominant strain? I will talk about vaccine rollout in South Carolina, including some of the ethical issues, some of the challenges. We keep adding people to phase 1A. What does that really mean? And to talk about vaccine future. So a little bit of biology background. And I think it's helpful to understand the terminology because often these words are used interchangeably. Coronaviruses are a group of viruses. Some coronaviruses just cause the common cold, but there's also SARS-CoV-2. That's the virus that causes the disease COVID-19. That little cartoon of the virus on the right-hand side, what it looks like under the electron microscope. The squiggly yellow and black line in the center, that's its genetic code. We as humans have DNA in our genetic code. This particular virus has RNA in its genetic code. This is important because that means it's impossible for it to change your genes. It's impossible for you to change your genetic code. That's one of the myths I hear circulating sometimes. On the outside of that messenger RNA, I call messenger because it carries a message on how to make more virus particles. On the outside of that is a protein lipid coat that has one protein in particular I want to mention, and that's the spike protein. The spike protein is the important one because it attaches to the cell, and it's important in injecting the virus's RNA. It's also interesting that every one of the companies that are seeking authorization for vaccine in the United States focus on the spike protein. That's that critically important in action in creating an infection. A little bit more biology, this just shows that arrow where the spike protein attaches to the surface of the cell, it allows the rest of the virus to enter the cell. The virus essentially hijacks the cell's machinery for making more viral particles and then releases a number of new viruses. You probably know that the initial symptoms sound a lot like influenza. You get fever, cough, maybe shortness of breath, aching all over. And some people have no symptoms at all. Most people have mild to moderate symptoms. Unfortunately, some people get severe symptoms. And what's unique about SARS-CoV-2 is that it can affect any part of your body. And the reason for that is it causes something called widespread vasculitis. Any word that ends in itis means the inflammation of, like conjunctivitis or bronchitis. It's an inflammation of those body parts. Well, your vascular system is your blood vessel system. So just imagine if you have an inflammation of your blood vessels, that means basically you can get disease in any part of your body, in your heart, kidneys, liver, gut, brain, and it can be passed from mother to unborn child via the placenta. And there are adverse outcomes, bad outcomes in pregnancy with COVID-2, stillbirths, early delivery. We still don't know enough about what the effect might have on unborn children, but that's being looked at. Most people, though, I do want to emphasize, 80% of people who have symptoms have mild symptoms, last 2 weeks, and then they get over it. We hear a lot about the long haulers, people who have long-term complications of COVID-19. That is a serious concern. It may be that they have an autoimmune condition, but it is still a minority of people. And part of the decisions around who is in phase 1A have been made on the basis of mortality. 69% of the deaths that we have had in South Carolina are among those ages 71 and up. And 40% of those deaths were among people who were residents of long-term care facilities, skilled or assisted living nursing homes. 87% of deaths are those age 61 and above in South Carolina. And that's reflective of what's going on in the United States in general. Let's talk a little bit about vaccine. I like this cartoon because I think it's a good example of explaining how vaccines work, because vaccines provide a sneak preview. There's a wanted poster showing an image of the SARS-CoV-2 so that the white blood cells already know what this virus looks like, so that when it first is introduced into the body, the white blood cells, the antibodies, they've already recognized it and they can go to work immediately. There's no time delay in attacking that virus because a vaccine has been there. I mentioned that all of the vaccines that are approved all focus on that spike protein. I'm going to talk more about the two that are authorized for use now. That's the Pfizer vaccine and Moderna vaccines. Both of them use the same platform, the same technology. There is no whole virus in any of these vaccines that are coming up in the United States. There's different vaccines, for example, in China, they took a whole virus and weakened it, and they used that in their vaccine. That is not true for any of the ones in the United States. The ones in the United States all all address that spike protein. So for Pfizer and Moderna, they have taken the messenger RNA or mRNA, just a little snippet of genetic code. They wrap it up in a lipid coat, in an oily coat, inject it into the muscle, and then when it's taken up by the cells start making that spike protein and release it. And the immune system creates antibodies, and some other immune systems, such as T cells, natural killer cells, become created by your immune system. The two vaccines are really very similar, Pfizer and Moderna vaccines. They both use that same platform with messenger RNA. Again, you can't get COVID-19 from the vaccine because it doesn't have the virus in it. It has just the gene for this one protein. They're both 95% effective after 2 doses. There have been no serious safety concerns, not only not in the phase 3 study, but even today where we have almost 30 million people in the United States have received the vaccine. They differ a little bit in the timing. You give the second dose for the Pfizer vaccine about 3 weeks later, second dose for Moderna about 4 weeks later. There is some wiggle room in exactly when you can give the second dose. Both of them do induce mild to moderate symptoms after the second dose, aching at the site of the vaccination. Some people will get some swollen lymph nodes in their armpit after the vaccine, aching all over, fatigue, maybe fever. But for both of them, it lasts maybe 1 or 2 days. Now, I've had a number of colleagues who've had the vaccine. Some of them said they had no symptoms at all. Others said if they had to give a comparison, they would say it was like halfway between the flu vaccine and the Shingrix vaccine in terms of what symptoms they experienced. We got our first shipment of Pfizer vaccine on December 14th in South Carolina. This is the vaccine that needs to be kept extremely cold, minus 90 degrees Fahrenheit. It is possible to roll that out to sites that don't have a freezer with that capability. They can keep it super cold on dry ice. We sent it first to workers in healthcare settings for a variety of reasons, wanting to vaccinate the healthcare setting to make sure that we don't get an overwhelmed, not interrupt our hospital capacity, but also some concerns about maintaining the cold chain. We wanted to start in hospitals first. The Moderna vaccine, we got our first shipment December 28th. This is a lot easier to handle logistically because you can store it at normal freezer temperatures, and it went first to residents and staff in long-term care facilities because that's where we've had our highest mortality. As of this time, everyone who was willing to accept a vaccine in those nursing home facilities among residents and staff have received their first vaccination. Some have gotten their second one. So some people in nursing homes are fully vaccinated. Some workers in healthcare settings are fully vaccinated. And one further comment about the timing of vaccine for first and second dose, because I know we have more vaccine demand than we have supply right now. And that has caused some delays in people getting their second dose and people concerned that they're not going to get that second dose on time. It's ideal to get your second dose in that time frame I mentioned, but it's okay if you get it later. I mean, people in the phase 3 studies were getting vaccinated as much as 6 weeks later, and it was still 95% efficacious. So it's important not to give the second dose too early. It's okay to give it later. The reason it's not ideal is after your first dose, you're about 50% immunized. So you have some protection, but you don't have as much immunity, and we don't know how long it lasts. So getting your second dose later, you'll get that full benefit. But meanwhile, in between first and second doses, of course, you're not completely covered. What symptoms go with the vaccine? Well, I think it's important to talk about the possibility of local or total body symptoms so that people aren't surprised. It would be a shame for a person to get a first dose of vaccine and then say, oh, the next day, I had to take a day off from work. I was really knocked out. I'm not going to get that second dose. That would be a shame. I said that the vaccine gives you about 50% effective immune coverage after a single shot. However, we don't know how long that lasts. That's why you need the booster. So I think it's important that people know about the symptoms so they're not surprised. I had mentioned earlier that there were no serious adverse outcomes, but there have been serious allergic reactions. The reason I'm not calling those severe outcomes is because they're treatable. And for Pfizer, so far in the United States, it's been about 5 anaphylactic reaction or serious allergic reactions. These are reactions where you feel short of breath, your blood pressure might drop, you need a shot of epinephrine, or you might even need some IV fluids. About 5 per million doses for Pfizer, 3 per million for Moderna. Is that a real difference? I don't think that's a real difference. I think, Moderna came out 2 weeks later than Pfizer. Not as many people have received it. I think this just hasn't settled out yet. And remember, where did we put Moderna in South Carolina? We gave it to the most fragile of our elders, those in nursing homes. And to put that in perspective, for other vaccines, like the influenza vaccine, serious allergic reactions occur in about 1 in a million. So yes, it's a little bit higher in Pfizer and Moderna, but not extraordinarily so. This is not a real surprise. To put it further in perspective, penicillin, the serious allergic reactions are about 1 in 5,000. So allergic reactions, these are foreign proteins, foreign oils, it's not surprising. The mild to moderate symptoms I've already mentioned, and I do want to emphasize that those symptoms are a sign the vaccine is working, that your immune response your immune system is responding. You have a sore arm because you have first responders that go to that area to attack that foreign protein that was just injected. It's swollen lymph nodes because revving up your immune system. Let's shift a little bit to vaccine allocation. Originally, the individual states' vaccine allocation from CDC was based purely on per capita. It was not based on how bad the outbreak is in a given state. It wasn't based on age. It was strictly per capita. Recently, it's been adjusted. And so this is the amount that we get from the federal government. It was adjusted to not only be per capita, but to also include the percent of doses successfully administered thus far and the number of residents aged 65 or over. That percent doses successfully administered, that has two implications. One is when there's been concern that vaccine rollout has been irregular and that some states are not doing as well with vaccine rollout as others. And so I think this was meant as an incentive. This is a carrot and a stick. But also think about the second dose. You want to make sure that your allocations you have enough allocations to satisfy giving the second dose. Allocations are made on a weekly basis, and this is confusing, but I thought you might want to know how this works, because one of the frustrations has been that we don't know how much vaccine we're going to get until just a few days before we get it. And that's that frustration, I know, goes downstream to the vaccine providers. We've got vaccine providers all over the state, more than 1,000 locations, but not all of them have vaccine right now. And they want to know, when are we going to get our vaccine? Our locals want to know. When we don't know how much we're going to get until a few days before, we don't know how much we're going to be able to send out. The states are told what their first dose allocation will be on a Tuesday. So we can then place our orders on a Thursday, and then we get that shipment the following Monday. Second dose orders are placed on Sundays, at an appropriate interval between 2 and 3 weeks later, according to whether it was Pfizer or Moderna. So this is constant, just-in-time allocations and decisions that are being made. I have heard that the new federal administration is interested in changing this system to give us more advance notice, but I know that it's difficult for them too, because literally Pfizer and Moderna don't know exactly how much vaccine is going to be available until just in time. Because remember, it's not just how much vaccine is made. They have to do quality assurance. They have to do testing on, on a sample of vaccine just to make sure that there was not any error made during vaccine manufacture. So the shipments occur after the jurisdictions place orders. Sometimes it's over several days. So, there are a number of issues still with rollout that are purely logistic issues. This is a screenshot of what's on our website, and it's already inaccurate, needs to be updated, right? Yesterday it was announced that we're going to move everyone age 65 and older into phase 1A. So I would take what's up here with a grain of salt, but I'll walk through it and tell you what things may change. So currently we're in phase 1A. Healthcare workers, and that's not just doctors and nurses, that's anybody who's working in a healthcare setting. So that's going to be orderlies, nurses, aides, EMTs, the long-term care facility residents and staff. We have an idea about that, and I'll show you a map about that in a moment. We have an idea, we can estimate the number of people in both of those groups. The moving target is when we start adding some additional groups to phase 1A. The challenge of adding people to more people to phase 1A, of course, is delay in getting to some of the others. Currently in South Carolina, we went with what the Advisory Committee on Immunization Practices suggested. And they suggested, that was ACIP, they met in December. It's not all CDC people, but it is run by CDC. When they met, they advised phase 1A be those healthcare workers, long-term care facility residents and staff, but that phase 1B be frontline essential workers. And we talk a little bit about how to define that. And then they recommended that phase 1C be people who had those underlying medical conditions that placed them at increased risk, and people age 65 and older. We're looking at that more closely in South Carolina. As phase 1A starts to shift, we have concerns about people with underlying health conditions being potentially in line behind, for example, healthy young, 25-year-old grocery store worker who, yes, they interface with the public. They are at increased risk of contracting COVID-19 because they have that interface. On the other hand, they're really unlikely to have severe disease. So these are complicated ethical questions. Let me tell you a little bit more about allocation in South Carolina. I already mentioned phase 1A, workers in healthcare settings, residents, staff, long-term care facility. We have been doing in phase 1A facility-based distribution because we know where those workers, those residents and staff are. So our plan had been phase 1A, go to the hospitals, go to the clinics, go to the places where those workers are. When Governor McMaster added age 70 plus to phase 1A, it created some changes in how we want to do vaccine allocation because 70 plus is everywhere. This new plan of adding 65 plus, it complicates it that much more, that we recognize that we need to have broader coverage. We need a broader footprint throughout the state, not just having it very, very hospital-based. We need to get it out to the smaller clinics, those private practice providers, to pharmacies, all the little pharmacies, not just CVS and Walgreens, but all the little pharmacies around the state. And so we're working on doing that. We're limited just by sheer numbers, sheer amount of vaccine. As I think has already been mentioned, the DHEC Board of Directors had an interim vote for regional allocation that would be strictly per capita. And I listened in on that meeting. I think they were making that judgment because they had the impression that that's going to be easiest, well, I guess it is, easiest, but they also had the impression that that would be fastest and be most efficient in getting vaccine into arms. We're concerned about getting vaccine into the right arms, not just arms. So the alternative plan that was suggested is not only per capita, but also taking into consideration regions, counties by age, and also something called the Social Vulnerability Index. The House has also voted, I think, I'm not sure if this was also mentioned, that this vote about the establishment of the 4 regions in South Carolina, regional subcommittees that would help to further manage allocations locally. But that is being voted on in the Senate as well. Right now, if you're eligible for vaccine in South Carolina, you can go to the vaccine, there's a vaccine locator map on the DHEC website that'll show you the green dots or places that have been activated. Those are the vaccine clinics or doctor's offices or pharmacies that have been activated, meaning that they receive vaccine. The red ones are the ones that are eligible to receive vaccine, but we haven't gotten vaccine to them yet, solely because we don't have enough to go around. When you use this map, you can click on one of those green dots, and it will take you to, it will show you the website, the web link for that facility. So you click on a green dot and it says, CVS Pharmacy. You can then go to that website and follow their instructions to make an appointment for vaccine. One problem with this website is that you have to shop around. You have to click, click, click to find a place that has appointments that work for you, because just because it's green means that they have vaccine. It doesn't mean that they have appointments. We're working to change this so that we can have a one-stop shop vaccine locator, so that you can put in your zip code and say whether you're willing to get vaccine within 25, 50 miles, put in those parameters. It'll tell you what places, what dates, what times appointments are available. It's not up yet, but it will. We know that this is a problem. We're working to fix it. We do have a 1-800 number right now on this website as well. So if people are trying to do this and having trouble, they can call for information, call for instructions. And also we are partnering with AARP, because we know, especially a lot of elders, but not just older people, not everybody is tech savvy, not everybody has an email address. We are working with AARP. They want to set up a 1-800 line so that people can just call them and they will make an appointment for them. Vaccine utilization. I mentioned that our allocation also depends upon how much vaccine we have been able to get into arms. And I know that South Carolina has been several times in the newspaper reported as being last in the nation in terms of vaccine utilization. And that's been a puzzle to us, because that's not how we saw those numbers. It was a glitch in the system with how CDC was accounting for vaccine administered, because we've got 2 systems going on, the long-term care facility and the other system, and the numbers were not communicating. So the long-term care facilities were dropped out. So, it just was a glitch in the reporting system. It has been fixed. And just to give you a link so that you can look if you want to be following this over time, there is a group, Becker's Hospital Review. It's a National Healthcare Information Forum. And this is its most recent release of the daily states ranked by percentage of COVID-19 vaccines administered. I'm relieved to report that South Carolina is the 5th ranking state. 78% of total doses of vaccine received in the state have been utilized, and that's up 10% from last week. The other states that are also doing an extraordinary job, it's interesting, North Dakota, West Virginia, South Dakota, and New Mexico, they've all had big outbreaks. So it's interesting. I think they have less vaccine hesitancy than some other states, because they've seen more outbreaks. This was the slide that I was adding last minute. What are these issues around phase 1A? Originally in South Carolina, when we were thinking about phase 1A, we calculated that we would give vaccine only to those healthcare workers who were working with the sickest of the sick, the people who were in the acute care settings of hospitals with inpatients, and maybe not just intensive care unit, but working with patients in hospitals, because if those workers dropped out because they got sick or even just had to quarantine, that we would be in trouble with our hospital capacity. We estimated that that was about 150,000 people in South Carolina. If we had stayed with that plan, we would have been out of 1A weeks ago. But then ACIP, that advisory committee, met in December, and they said, we recommend that all workers in healthcare settings be vaccinated. And so we went with that plan, and that increased it to 350,000 people. But even still, we've administered already more than 350,000 doses of vaccine in South Carolina. We would have been through phase 1A by now. When age 70 plus was added, that meant our phase 1A was about 1 million people. I don't know what it means to have added age 65 plus, because it's not just how many people age 65 to 70 were added. You know, there's some overlap. Some of those people who are 65 and over are also workers in healthcare settings. They may be people in long-term care facilities. So I don't know the numbers, but it adds more. What if we add teachers? Well, I have certainly can appreciate the perspective of teachers who are scared to go back to school. There have been teachers who have died of COVID-19. At the same time, I know that some teachers are at greatly increased risk because they have other conditions. They may have diabetes and hypertension, which make them at increased risk for severe COVID-19. There are also younger teachers with no medical problems who, if they got COVID-19, they would probably have mild to moderate symptoms and not severe disease. And if they are in phase 1A, we will have phase 1A for a much longer time, and that will delay getting vaccine to people who are out in the community who have severe other medical conditions, but they're younger than age 65. And so, it's an ethical, true, what have we seen? Well, turns out schools are remarkably safe settings. We are not seeing a lot of school-related outbreaks. We are seeing teachers, we are seeing students who get COVID-19. It's often associated with out-of-school sporting events, out-of-school gatherings. And so I'm not sure what will happen when we add teachers in terms of what that might mean for morbidity and mortality in the state. If our number one goal in the state is reducing deaths, then certainly adding by age makes a lot of sense. Adding teachers is a really complicated question. I took these screenshots on February 1st. Of course, these numbers have already changed, but this is on our website. It's updated daily, and you can go to our website to follow this if you wish. Vaccine allocations in South Carolina as of the 1st, we had over almost 700,000 doses received. We've received new doses right on Thursday, so we place orders on Thursdays. We receive new doses on Mondays, but we receive second doses later on in the week also. But be that as it may, just to walk you through this, about 700,000 doses received in South Carolina, and over 400,000 doses given, but that's because it breaks down into different types of vaccine in different localities. Of the Pfizer vaccine, that's the one that goes to workers in healthcare settings and age 70 and above, 92% of those have been have been in arms. The Moderna vaccine has been going strictly to long-term care facilities. We've just started getting it to other places as well. And so to avoid confusion, because you don't want to mix and match these vaccines, we do not want to have facilities that have both, because we're concerned that that's going to be the potential for people getting one dose of one vaccine, the booster of the different vaccine. So the Moderna vaccines right now, we have allocated to some mass vaccination clinics that DHEC has done. And that rollout is still a little bit slower, but still about 56,000 have gotten the first shot. 2 people have gotten the second shot. And so 50% of those doses used. If you really want to drill down, this too is on our website and updated daily, that you can look at the Pfizer allocation that goes directly to facilities, how much first doses, how many second doses, how many have they gotten into arms. And as I said, this is updated daily. These are vaccines that go straight to the facility. We also have other facilities that want vaccine, but they want smaller amounts. Pfizer vaccine logistics are also messy because they send it in units of about 1,000 doses of vaccine. You can't order less. It comes because of this special cold chain. You have to order large amounts. So what about the places like Tidelands Health Rehabilitation and Murals Inlet that only wants 45 doses? That's possible. It comes to DHEC first, and then we make arrangements to maintain that cold chain to get it to those smaller places. So you can see what that allocation is as well. What about Moderna for long-term care facilities? This is run through a partnership of CDC and the pharmacies. This is not under direct DHEC control. The vaccine allocations we control, but we don't control the administration to the long-term care facilities. There has been remarkable vaccine hesitancy among the workers in long-term care facilities. What these maps show on the left are the percent of persons who are residents in long-term care facilities who have received at least 1 dose of vaccine. And you can see in South Carolina, that's between 60 to 79%. On the right are the percentage of staff members who have received at least 1 dose of vaccine. In South Carolina, that's fewer than 40%. Now, some of those people may be waiting to see, I'm going to see how everybody did, how all these elders did with their first dose of vaccine. And if they did okay, they may have vaccine uptake. But we know that there's a lot of vaccine hesitancy. People are still concerned. Some people are anti-vaxxers. They're never going to get vaccinated. They think that this vaccine especially raises additional concerns because of that feeling that production was rushed. I can talk about production if you wish. There's lots of reasons to believe this production was not rushed, but I'll focus on that if you want me to. What is the story with the new variants? The British variant, B.1.1.7, is shown in green on this map, and it's certainly more widespread than this. We just haven't found it in all states yet. B.1.351 is the South African variant that has been found in South Carolina and in Maryland. It's also most certainly more widespread than that. There's also a Brazilian variant, and that's been found in Minnesota. Will the current vaccines work against these new variants? Yes, for the British variant, and it's less effective for the South African variant. But let me tell you a little bit about how they do these studies. They take serum from people who have had the vaccine, and they look at it in the test tube to see whether they have neutralizing antibodies against these. They make pseudoviruses. It's dangerous to deal with these viruses in the laboratory. So they make fake viruses that have, there's the name of some of the fake viruses. The UK Delta 8 means it's got the same 8 mutations on the spike protein as the British one. The South African Delta 9, it's got the same 9 mutations, and wild type means the regular virus that's been circulating. And the loss of neutralizing antibody is really small for the British vaccine. Remember, these vaccines are 95% efficacious. They give you a higher antibody level. The vaccines give you a higher antibody level than natural infection. So we can afford to lose a little bit of effectiveness. But it's still a concern about the South African virus. Are vaccines going to be as effective? I would remind you, though, that even if they are not 95% effective, if the vaccine reduces the chance of you getting severe disease, then that's very worthwhile. If all they do is, it's like the flu. Even if it doesn't 100% prevent you from getting the flu, if it lessens the severity of the flu, vaccine is worthwhile. What about those monoclonal antibodies? Will they work against these new variants? Regeneron has studied this, and their monoclonal antibodies neutralize the British and South African variants. I don't think Eli Lilly has done this study, or maybe they're doing that study with the bamlanivimab. I don't have that information yet. They haven't revealed that information yet. But if Regeneron works, I would think the bamlanivimab would work as well. The British variant contains the same mutations as the South African, so it's thought that it should work for the Brazil variant as well. What do we not know? Well, we don't know if these new variants will respond to remdesivir and these other drugs that are used for, probably the dexamethasone steroids would continue to work, but some of the other medications that are being studied, they're studying it right now to find out whether they will work against these new variants. What if you've previously had the wild type, the original COVID-19 infection? Will that protect you against new variant reinfection? That's being studied right now. CDC, as DHEC is certainly looking at this, but CDC is looking at this nationally as well, asking states to report people who get reinfected so that they can look at their genome sequence to see whether this was a new variant. It's thought probably that if you get reinfection, again, that you would have antibodies, T cells, that you would be able, maybe you would get reinfected, but it should be mild. What about rapid tests? The rapid tests look at the protein on the surface of the virus. And if it's that protein that has a mutation, will the rapid test work? Rapid tests might not detect new variants. The PCR tests will, though. The PCR is the gold standard, the nasal swab, oral swab, they should still work because they look at multiple targets. What we are concerned about is, will the new virus variants lead to an increase in deaths? Yes. If they spread more quickly, you're going to have more cases, you're going to have more deaths. We don't have solid evidence that these new variants are more lethal. It's just that they spread more easily. They may be more lethal, but we don't know that yet. So that's why the mask message is more important than ever. People who've heard me speak before know that I like to end my sessions by talking a little bit about masks. Let me try and give you a little bit different information, because nowadays everybody's talking about, should I wear 2 masks? Should I wear more than 2 masks? The best masks are those that are well-fitting, that are at least 2 layers, and ideally of different materials, because it's not just a mechanical blockage. If you have 2 layers, the first layer, yes, it's a mechanical filter of aerosols that'll stop a lot of droplets. Some of them are still going to get through, but that second layer, especially if it's of a different type of material, sets up an electrostatic filtration, an electrostatic charge. Have you ever walked across a carpeted floor in the winter when the air is really dry, and then you touch something metallic, you get a little electric shock? The same principle is going on here, that having 2 different materials, you get a little electrostatic charge. What that does is it helps capture viral particles, because of course virus is smaller than the weave of any cloth that you can breathe through. What stops virus particles is that they do respond to that electrostatic charge, and they're more likely to stick on that second layer with the electrostatic charge. What about double masking? My concern about double masking is that people will cheat by having 2 masks on. They feel that they can't breathe, so they loosen the ear loops and completely negate the whole purpose of masks, as now air can get in through the sides or through the nose or under the chin. So the best masks are at least 2 layers. Personally, I like a mask that has 2 layers and a pocket that I can put in a filter. And that doesn't have to be a magical special charcoal filter. It can just be a 3rd layer of a different material, nylon, a piece of silk, as that middle layer. Some people, I've seen Tony Fauci do this. He has a surgical mask on first. Surgical mask is not just a paper mask. It's a specially made paper mask. It's actually got 3 layers, and that 3rd layer, the innermost layer, the middlemost layer has a baffle. It's almost like having an extra woven type of material that sets up that electrostatic charge. So the idea here is, if you want to double mask, that you wear a tight-fitting surgical mask as your bottom layer, and then you have a cloth mask on top of that. It doesn't have to be as loose. It is acting more as that mechanical filter. I'm going to stop there so that we have enough time for questions. I also have my email here on this last slide, and I will forward the slides so that you'll have them. You're more than welcome to use these slides, share these slides widely with others, or email me any questions that we don't cover today. Thank you.
Thank you so much, Dr. Kelly. I am having internet issues. I'm having to run it through my cell phone right now. So I have received some questions through chat. I'm going to read those, and the one I got on text message. If you guys cannot reach me through chat, we're just going to have to very orderly kind of raise your hand, and I will write down the names of everybody that has questions. But if you have questions, please try and send them through the chat box. That will be the easiest thing, but I am having issues. So, all right, first question, Dr. Kelly, has there been consideration to vaccinating super spreaders who are young in South Carolina?
We have talked about that, and that's a model that's been used in other countries. The idea here is why vaccinate all when we know there are super spreader events, and it's almost like that 20%, 80% rule, where 20% of people are causing 80% of the events. We think that that is true for in South Carolina as well. And you are right that many of those events are associated with young people who are paying no attention to masking mitigation measures. There's such a large number of people. We felt with limited, that might make sense if we had a huge amount of vaccine available. That would be a smart way to go. We did discuss this. We decided with such limited doses of vaccine, what we need to do is vaccinate the most vulnerable first. And so that's going to be a longer time before we bring this pandemic under control. If we had unlimited vaccine, that would be the way to go. But since we don't, we're going with the most vulnerable first.
Okay, thank you. Second question is, the VAMS portal is extremely difficult to navigate. We have been hearing about a new portal for weeks. What exactly will it look like, and when can we expect to see it? Will it be available for the 65 and over crowd?
Yes, so there are two issues here. One is that map that I showed earlier of making an appointment, and the other is VAMS, which is, when vaccine is given, somebody's got to type in all the information about that individual. And that is definitely slowing it down. VAMS was originally designed to be used in healthcare settings. And so it was thought that, hospital systems could do this more easily, but even in hospital systems, it's full of glitches. The new portal that I mentioned, I was part of the pilot test that we did at DHEC, and it was easy. It was great. Put in my information about, who am I, to justify that I'm in this phase, whichever phase it may be, put in my locality information, put in the, where I want to get vaccine, and I got an appointment and immediately got an email message. I could have asked for a phone text instead. It was very simple. When is it going to roll out? The concern we had was it's been tested with hundreds of people at DHEC. What happens when we roll it out and thousands or tens of thousands of people are using it simultaneously? So IT is worried about the rollout. So I think they're still working on glitches with that. Originally there was hopes that we might have it out even by now in early February. So I don't know from an IT point of view exactly when it is due, but we know it's urgently needed.
Okay, thank you so much. Next question is, Prisma Health and MUSC are receiving the bulk of vaccinations in the state and using them for mass vaccination events. How can Beaufort County ensure getting our fair share for max vaccination events as well? Quickly.
It really is an allocation. It's a distribution issue based on how much vaccine we get at any given time. So yes, the focus was on the big players first, because they were the ones that we felt were best able to roll out their mass vaccination of the people they serve, as well as their workers. Just so folks know, both MUSC and Prisma asked for twice as much as what we gave them. That we did not give them everything that they wanted. And that right now we are continuing to receive requests at about 4 times the amount of vaccine that we have. But we are aware of the need to spread it more widely. And I think just as, if you look at those vaccine utilization rates, we know that Hilton Head Hospital, some other areas have done an extraordinary job. Often their utilization rate is more than 100% because they've been able to squeeze a 6th or even 7th dose out of a vial. So the vaccine will continue to come to those areas. But I'm not involved in the allocation decisions. I personally, but I will pass on your request and concern. I think the vaccine task force is aware of we need to spread this more widely, especially since we are no longer focusing just on workers in healthcare settings. We're focusing on older adults. We need to go where the older adults are.
Okay, thank you. My next question is, do you have an estimate of how many in South Carolina will refuse the vaccine? What is the impact of that number, and what is or will South Carolina do about that?
Yeah, this is a very worrisome thing. And there may be, I mentioned vaccine hesitancy. Vaccine hesitancy is a moving target. I think it'll change as people see that other people have received the vaccine and had no serious consequences. Some people who are hesitant right now will accept vaccine later. For example, there have been both national surveys and South Carolina surveys that have looked at vaccine hesitancy stratified by age, racial demographics, education level, and vaccine hesitancy was higher earlier in this year, like in the summer, when Operation Warp Speed was, constantly in the news, and they were recruiting people for phase 3 studies. Vaccine hesitancy is decreased, and I can add some slides when I send this presentation to you. I can add some slides I have about that. Has decreased. What are we doing in South Carolina? Well, number one, we're doing things like this. I'm not the only one who's speaking to groups. We've got a number of people who are speaking to various groups about vaccine hesitancy, including we have seen the greatest hesitancy in the African American and Hispanic Latino communities. We are working with community health workers who work in those communities, as well as faith-based institutions. I've done a number of presentations to different AME churches, for example, as does Linda Bell, and trying to answer their questions. The number of rumors, some of which are really wild, and conspiracy theories, especially around this vaccine, is something we've not had to deal with before. It is outreach to those particular groups, because the concern is if we don't reach herd immunity, that this will be a kind of a never-ending process. You may get vaccinated and now you have immunity to the virus, but it will continue to circulate. We'll continue to see hospitalizations and deaths until we can reach a certain percentage of the population vaccinated. What percent of that population? A lot of modelers use the estimate of 70%. It's complicated to arrive at that number. It depends upon the biology of the virus, but it also depends upon people's behaviors. So in order to stop a pandemic that with high case rates like we have right now in South Carolina, it's probably going to take more than 70% herd immunity to stop progression. What's the timeline for that? Well, remember, we don't even have a vaccine for those under age 16. It's going to be months before we have vaccine available for vaccinating those under age 16. So we're still in this for a long haul. Okay. To not just end on that pessimistic, say something optimistic. We have, South Carolina right now just has Pfizer and Moderna vaccine. Johnson & Johnson, AstraZeneca, the Novavax vaccine, those are all looking good. They will probably be available. Yes, they have a little lesser efficacy than the Pfizer and Moderna, but what's our goal here? If our goal is preventing deaths and they prevent 85, if they're 85% effective in preventing death, then that's enough to stop a pandemic as well.
Okay, well, thank you for that good news. That's good. The next question is, what can you tell us about when self-tests may be available?
Self-tests are already available, but they're expensive. You can order self-tests from Amazon. You can get self-tests at your local pharmacy, but I think that they cost about $25 to $50. So they're really not very good for the general public, but they're available now. You can order them online.
Okay, thank you. Next question is, what is the advice about wearing a mask to people who have had the vaccination?
Excellent. Thank you for bringing that up. I mentioned if you had a single dose that you're about 50% effective, and that's on average. So you might be less than 50, you might be more than, you might be less than 50%. So certainly after your first dose, you don't consider yourself protected. What about after your second dose? It's estimated that neutralizing antibodies will occur about 1 to 2 weeks, 2 weeks after the Moderna second dose, 1 week after the Pfizer second dose. A person would have the antibodies, would be protected. However, you may be protected from symptomatic illness, but that doesn't protect you from getting the infection. It is possible for a person to be vaccinated, be exposed, and then get asymptomatic infection and be contagious and spread it to others. So there lies the rub. So our recommendation right now, until we get many, many, many more people vaccinated, is even when you're fully vaccinated, to please protect your community, to continue to wear a mask. And one other feature, we're still not certain, right, that this will protect you from the variants. So that's a second reason to continue wearing a mask, even after you're fully vaccinated.
Okay, thank you.
Tracy, why don't we take 1 or 2 more quick questions, then we've used up quite a bit of Dr. Kelly's time.
Okay, I have, and Dr. Kelly, I don't know if you have time. I have a lot of questions that are.
I have time. I mean, I'm hogging this call and I'm giving you long answers, but I know that you're going to communicate this further. So these are important questions. I want to answer them.
Okay, well, we'll try and do as many quickly as we can. Here's one. What about the use of NSAIDs to treat symptoms of the vaccination? Would they interfere with the desired immune reaction?
The best thing, if you have some, the symptoms that I was talking about post-vaccine, the best thing to use would be Tylenol, because acetaminophen, it doesn't interfere with your immune response. Ibuprofen, other NSAIDs, they do mildly interfere with the immune response. So if you've got mild symptoms and you can put up with it for a day, I would say just take Tylenol. If you're having, moderate to severe symptoms, you're lying in bed aching all over, take your ibuprofen. I mean, that's just a sign that your immune system is really, really revved up. Yes, I wouldn't take an NSAID routinely, like, should I take it before I get the vaccine? No, because you might not have any symptoms at all. But if you're having moderately severe symptoms, go ahead and take it.
Okay. Next question. Will smokers be given a priority considering their vulnerability?
Smokers are at some increased risk for severe COVID-19. And that includes former smokers, smokers who have since quit. It's much lesser risk than some other medical conditions like diabetes, hypertension, heart disease, obesity. So we're discussing that in South Carolina right now. So, the recommendation out of ACIP was including smokers. CDC also includes smokers, but this comes down to should they be prioritized ahead of some of the other medical conditions? Are they in the same boat as other medical conditions? And they're not at the same level of risk. So we're not in that phase yet. So we're still looking at that data to make that decision.
Okay. Next question. Now that Beaufort Memorial Hospital and Hilton Head Hospital, Coastal Carolina, have proven to get shots in arms in around 125% and vaccinate the elderly and underserved communities, who do we talk to about getting more?
I will communicate this to our task force. I'm trying to think of what it would be I think the email address to send this sort of thing to is the operational people, and that would be ACC-Info immunization. That goes to the task force team that I'm talking about.
Okay.
So,
Yes, got that. Jenny, I have 11 more, I have a ton of questions.
I'll talk faster.
Okay, okay. Do we do that one?
Tracy, why don't we do this? For those who have commitments they need to fulfill, they can go ahead and drop off the call since Dr. Kelly so kindly said she'd answer our questions. Obviously, we got a lot of questions, so if you still have questions, please stay on. But for those of you who have to leave, we understand.
Okay, great. Next question. It seems as if the Regeneron treatments have been difficult to administer, unlike the availability of vaccines. Is there a plan to improve administration of Regeneron to reduce hospitalizations and severity of the illness?
We have another issue with just availability. We get limited doses of Regeneron and bamlanivimab. So I know that the demand exceeds supply. There is a plan to get up on the website where Regeneron and bamlanivimab are, where it's available, so to try and reduce the confusion of people calling around and finding out, oh, this hospital doesn't have it, where else can I go? I don't think that map is available yet, but I know that there is a plan to get that in place.
Okay. Let's see. You have a slide showing your demographic targets for the two different vaccines. By what criteria did you make these determinations? Is it more about effectiveness or more about storage conditions at a particular location or something else?
It was logistics. So we were asked by CDC to pick one to go to long-term care facilities. They were, again, wanting to remove that confusion, the potential of people getting a mix and match, one dose of one and a different dose of a dose of the other vaccine. So we chose Moderna to go to long-term care facilities simply because it's going to be easier. It was simply logistics.
Okay.
Those two vaccines are essentially the same in terms of efficacy and side effects.
Okay, perfect. Let's see. Is it true that certain blood types do not get COVID?
This is very interesting that certain blood types have a reduced risk of getting COVID, or at least getting symptomatic COVID. And that might be the real key. On the surface of your blood cells, you have these things called histocompatibility complex proteins. And it may be just that it's better able to either fight off the virus when you're exposed. But it is true, certain blood types are less likely to get severe disease. It's not well understood why.
Okay. Next question is, do you have any insights into the source of the virus, how it developed, and to address the conspiracy nuance that says it was developed in a lab in China?
So thank you for that question. I don't know how many people in this call have visited developing countries or specifically been to China. China has what are called wet markets. This is sort of like a farmer's market, only with live animals, live fish, but also live mammals, birds. And people in China want to buy their food, their meat, fresh. They literally want to see the live animal and have it killed in front of them to get that food. Can you imagine what that looks like? I'm not talking about, in butcher shops. I'm talking about outdoors, concrete floor, animals in cages, birds flying overhead, bats flying overhead, and that certainly China has sparkling, shiny malls and sophisticated areas as well. But they also have these popular wet markets where there is literally blood and guts on the floor and animals interacting. And so there's a tremendous interchange of infectious disease, interchange of viruses that get passed from birds and pigs and exotic animals like pangolins and civet cats. So it's such a setup for mix and match viruses, for animals exchanging viruses. I know from what I've read, I'm not a molecular biologist, but I've been reading the molecular literature. The molecular biologists believe that this vaccine comes from nature for several reasons. One, genetically, it is very like the pangolin virus. no, just when they look at the genetic code. Number two, they have said that if you were going to create a virus, you wouldn't, as like a bioterrorism weapon, you wouldn't create this virus because it has a number of, stupid steps. It has a number of things that make it less fit. Obviously, it's been plenty fit enough to spread in a pandemic, but their point is that if you were going to make an artificial virus variant, like if you were going to take the original SARS virus from 2003 and try and make it worse, you wouldn't have added these particular protein mutations. You would have done some different things. I just have to take their word for it. I don't understand the molecular biology well enough, but but their argument is that this would not be a good bioweapon, or it wouldn't be the way one would make a bioweapon, whereas there is good evidence that it came from nature.
Okay, thank you. I actually only have a few more questions, so I think we're getting down to the end. Someone asked, surprised and disappointed the first shot protection is only 50%. Media publicity, particularly in the UK, where they are delaying second doses to vaccinate more people with the first shot, was said to be much higher.
The 50% that I'm quoting is coming from the phase 3 studies. So it may be that, you do phase 3 studies in 40,000 people. Now that you're doing it in millions, essentially an experiment in nature going on in the UK, they're giving it to millions of people. So they may be right. What they're finding in real life is different from what they found in the phase 3 study with 42,000 people. So you start getting it into millions of people, you'll see things differently. And it may be that their strategy is not unreasonable. The idea of just but to my view, getting twice as many people to have only half vaccinated is it's a coin flip. Do you want, half as many people fully vaccinated or twice as many half vaccinated? Our view in the United States has been to go for that full vaccine protection and just try and get it, administered as efficiently as possible. What's going on in the UK may turn out to be a more effective strategy. And if it is, then we may shift.
Okay. When a person gets vaccinated, will they get a vaccinated person get a card or note that states they have been vaccinated?
Yes. So when you get vaccinated, the information goes into an electronic database. So if you lose your card, that information still exists somewhere. But you get a card that has the date of your vaccine, what type of vaccine you got, and ideally has your return appointment date. Ideally, you get an appointment made for your second dose right then and there when you get vaccinated.
Okay, great. One more question and then 2 comments. Let's see, the new CDC director, and you sort of covered this, but maybe you could just briefly speak. The new CDC director said teachers need not be required to be vaccinated. What are your thoughts?
I don't think anyone in South Carolina or anyone at DHEC is advocating for requiring vaccination. We didn't ask, for example, healthcare workers were not required to be vaccinated. And the same thing would be true for teachers, that we don't think that we would require vaccination. I'm not sure if that's quite what you're asking about requiring, or whether you want me to talk a little bit more about the ethics of vaccinating teachers.
Well, I think that you covered that, saying it's kind of like the younger grocery store employees.
Yeah.
Kind of have to weigh that, and that'll be a decision that comes. It has been asked, could you repeat the full email address of the operations, the ACC-immunization? What is the full email address of that?
Capitalized ACC dash, and then just the word immunization.
Okay.
Singular immunization.
And is it at what?
Oh, I'm sorry. Of course. I'm sorry. At DHEC, DHEC.sc.gov. I'm so sorry.
Yes, no problem. The last is from Jeremy Clark, who is the head of our Hilton Head and Coastal States Hospital. And he said, Dr. Kelly always does a fantastic job. We are fortunate to have her speaking to the GIC and working with DHEC. And on that, I will say thank you, and I will turn it over to Jenny.